So this is a case of a 53-year-old man with skin lesions and joint pain.
Maybe you first, me first.
Go for it, my friend, please. What do you think when you hear skin lesions and joint pain?
Definitely rheumatologic disease, but as this is middle, like this is not a young adult, this is like a middle-aged male. Maybe I can think also about viral diseases and then rheumatologic diseases. What else can I say? Of course, we will need a lot of background.
Yeah.
We don't know anything about him, but that's the nicest part of this mystery case.
Right.
So I don't know. Of course, when I hear about skin lesions, I would like to know what kind of skin lesions does he have, like in how are these lesions, where are these lesions, and how did they appear, maybe after a fever, before fever, how did they spread in the body, and when did the joint pain appear, maybe after or before or at the same time.
I think that's, it's, I don't know how much more you can take this data, and it's really cool to see you not jumping to a specific diagnosis, right? Because as we talked about a couple of morning reports ago, there's two parts to problem solving. There's the trying to clarify what the problem is, like what is the nature of the problem, and then what is the solution. And right now, I don't think we know the name of the problem. It's just skin and joint pain, but it could be a pustular skin lesion or a necrotic skin lesion, or it could be arthritis or arthralgia. So it's very hard to solve this problem. And I think that the mistake to make is to already start to think of individual conditions. And I think the only practice we can do is in real life, is there any diagnoses that comes to mind that might be life-threatening that you'll have a reflex to think about when you see skin lesion and joint pain? So maybe as a group, and Kiara, I love your thoughts. The differential diagnosis of this is probably over 100, 150 things. But are there any things that we should practice a reflex to never always think about in patients with skin and joint pain?
Yeah, so maybe the infectious part, maybe some staph infection that can disseminate and become and make this patient septic. That would be a big concern to me. Or a debut or exacerbation, for example, of lupus or some rheumatologic disease, and can make this patient worsening. Yeah, those two, or maybe viral infection debut that make these patients very sick. Those are my,
I completely agree with you. Whenever you see skin lesion and joint pain, you're going to have a lot of time trying to figure out what the diagnosis is. But a septic arthritis is the no miss. And the two important causes of septic arthritis are, of course, pyogenic bacteria like Staph aureus, which also can go to the skin, and then also disseminated gonococcal infection. So for me, I think you have to do a lot of work to make sure these aren't at play. So really kudos to you, Kiara, for not jumping to individual diagnoses when you have such a broad overlap, but the life-threatening ones are the only ones that we should develop an association for. And I think those two here. All right, Rafa, tell us more, please.
Sure, just a second. Okay, so 4 months earlier, this patient presented with right great toe redness, pain, and swelling. And he was treated empirically with superfloxacin with no improvement. 3 months earlier, he developed a left knee effusion. He was taken to the OR for a washout and treated with Benco and Clavelin. No improvements in symptoms despite antibiotic therapy, and his review system is positive for night sweats only. And that's the end of the aliquot.
Wow, intriguing. What do you think?
Yes. Okay, what I think when I hear toe redness is probably gout. We don't know if this patient has gout or not, but this is my very first concern.
Yeah.
And some patients with gout exacerbation, or just them because having gout can present with other joint pain. So yeah, this is my first concern. Um, I don't know which treatment he receiving, if he was given NSAIDs or any other anti-inflammatories for this disease. But instead, I still thinking about any infectious disease that can be precipitated in any other condition.
100%. You know, it's amazing. We have this like robotic recall, first toe gout, and it's so true. It's 100% true. In I don't know, I think it's probably like 90% of people with first toe inflammation have gout. So it's almost like what would move you away from that? And you know, the thing that's really scary, Kiara, is that he had knee inflammation so bad that he needed to go to the OR, operating room. And so that makes me wonder whether, like, that tells me with a high degree of certainty that they probably looked for gout and didn't see it. Otherwise, they wouldn't take the patient to the operating room.
Yeah.
So what do you think of that? That the knee was so inflammatory, they took him to the operating room, but they still didn't find that he still didn't get better with Vanco and Clovulin. What do you think of that?
Yeah. So first, the common etiology for knee fusion is trauma or fractures or those kind of things. So
Right.
I would like to know if maybe this patient had some trauma at work or at home or anywhere.
Right.
Then I would like to know if he had any fever. I know he never had night sweats, but after it says, but maybe he had fever or any uncommon findings for like an increased inflammatory markers. So sometimes infections are resistant to some antibiotics, and they don't improve, especially those that form abscess. So maybe he has an abscess, and that's why he is not responding to antibiotics. Or maybe this is not a strep or staph disease. Maybe this is a I don't know. At least in Peru we have
Beautiful.
TB with knee fusion. So maybe this can be the case. I don't know. At least of my diagnosis, I will be thinking about some malignant tumor causing some compromise of this joint. But as there was another one in the big toe, so maybe it is not the case.
Yeah.
Yeah.
I completely agree with you. I think that if you assume that he got good diagnostic and treatment testing, you'll say that this is infectious arthritis that is culture negative and not right? Like most of the time when we think septic arthritis, we think staph strep, but him not getting better with Vanco tells you that you're probably dealing with a very aggressive but non-pyogenic septic arthritis. But as you said, that's assuming that the people who were taking care of him logically went through those things. But I think that it's probably true they did, because to take somebody to the operating room is not a decision anybody takes lightly.
Yeah.
So I think we're starting to develop a schema for what are the causes of septic arthritis that are culture negative. And I love that you mentioned TB. TB is probably the most common culture negative cause of sepsis.
So
But
Lyme disease, I believe.
yes,
Yeah.
Lyme disease is a big one. Is a big one.
Yeah, especially there.
Yeah, especially with skin lesions, right? Like erythema migrans, for sure. So, but before we start to get nerdy and develop this list, I'll just make one point. All the causes of culture negative septic arthritis are caused by diseases that are exogenous or outside of the body. So staph, strep, E. coli are all diseases that live on your skin and they go in the joint. The differential diagnosis of culture negative septic arthritis is all by diseases of bacteria and fungi that live in the environment then come inside you. So it will be crucial to understand what his exposures are. Does he have tick exposure? Does he have TB exposure? Does he have fungus exposure? So I think this is one of those times where the bottom left-hand corner of the whiteboard is going to be a game changer, because it'll tell us so much about what exposures he has, which will inform the list of infections that are culture negative. Yeah. So Rafa, tell us more.
You ask, you shall receive. Okay, so let me do this. Basically, I'm cheating, writing in right and then converting to blue. Okay, so over the next 2 months, this patient developed multifocal skin lesions on face and extremities. Some lesions were painful, subcutaneous nodules that sometimes erupted in purulent material. Some lesions were raised erythematous plaques that occasionally had ulceration. Let's see here. Giving a little more of background for you too. This patient was born and lives in southeastern USA. He works as a supervisor of a landscaping company and participates in Civil War reenactment. Active tobacco use, no alcohol, and no recreational drugs. Do you want the physical exam as well?
Yeah, Rafa, why don't you just give us the exam as well? Thank you.
I think it's all unremarkable because there's no description, except they showed us
Okay.
the skin lesions.
Yeah, let's look. Wow. Oy, oy, oy.
There is one more image here on the nose.
On the nose.
And that's the end of the aliquot.
Paging Dr. Camacho. Tell
Not
us.
here. I'm not here. Oh, no.
What do you think?
So that this description of these skin lesions, when they say purulent material, I believe they are pustules, but then there are ulcerations. So some ideas of pustules, well, the common ones, acne, but as they are all over, maybe I don't think this is acne. Then some infectious diseases with pustules are all these staph, strep, or any other lesion that have been contaminated can develop pustules. But also one common lesion that develops pustules are gonococcus infections. So now I'm thinking about gonococcus infection. But then when they say vesicles, I already read in the chat that they are asking about hand-foot disease, because if they compromise the hand, they are thinking about some tick-borne, because he's a landscaping patient. He's one of his jobs is a landscaping, so I'm concerned about this tick-borne. Also, safe, but maybe I don't know, could be the case. So yeah, I'm right now I'm thinking about more infectious.
Yeah.
And in my second step, rheumatologic, but yeah, so far I'm thinking about some infection disease.
I completely agree with you. I think that
Also,
yeah, go ahead.
I don't know if TB can present with pustules in the body. I'm not so sure.
Yeah. I think you can say TB can present with absolutely
anything. Yeah, that's true. It's amazing.
I think that you're spot on in focusing on infections, because there's pus coming out of these lesions. And we already were inclined to think that this would be an atypical infection because it was culture negative. And then also the time course, 4 months is very much a atypical organism. And the question is, what clues did we get from the exposure history? And I think you're right. The exposure history means that he's outdoors a lot. And landscaping in particular gets you exposed to all the endemic mycoses. And so which endemic mycoses are common in southeastern USA? And it probably is mostly histoplasmosis, but also blastomycosis. And so we have to think about those two things. The interesting thing is to also consider the possibility of sporotrichosis, Though the involvement of the face is a little bit unusual with sporotrichosis. It's usually extremity predominant as it goes up. But I think, what do we know? We know that this patient likely has an atypical infection. And here's the most important thing. The vast majority of all the infections that we just talked about come to the body from the lungs. So even in a patient who is asymptomatic, you want to get an assessment of their lung by X-ray or even CT, because most of these things enter through here: blasto, histo, TB. So we have to, before we proceed, make sure that we have a good grasp of the case. And I think pulmonary imaging will help us stay on track. And if it's negative, then we're going to have to go a completely different way. All right, Rafa, tell us more.
Okay, so I'm gonna give you the CBC first. The white blood count was 10.2 with 87% being neutrophils, hemoglobin of 8, and platelets 540,000. The CMP, completely basic metabolic panel, was completely unremarkable. The RPR was non-reactive, serocryptococcal negative, serum histoplasma antibody negative, Hep B and C serologies both negative, ANA and ANCA negative, normal complements, and HIV negative. And I'm stopping there.
What do you think, Kiara?
Well, many rollouts.
Yeah.
That's great, I think, because that narrows a lot our diagnosis. I suppose that those platelets are elevated, right? So I just know about, in this case, I can relate these high platelets with some inflammatory disease.
Yes.
Nothing more that I can.
Agreed.
Yeah, and these white blood cells is like, I realize this is upper limits and a predominance of neutrophils. Maybe this is also related to an inflammatory disease that does not say further things. What do you think?
Yeah, I completely agree with you. I think we've proven that he has chronic inflammation with those thrombocytosis. And I think that pertinent negatives are so helpful. And the most pertinent negative here is that he is HIV negative. Because, Kiara, this whole time we're saying this person has an atypical infection, right? Like TB and all those things. But who gets a disseminated atypical infection like this? Usually it's people who are immunocompromised, right?
Mm-hmm.
So I think we have to now step back and say, which one of the infections that we talked about is most likely to disseminate in a normal host? Any thoughts on that? So we said TB, histo, blasto, cocci, Lyme. Which one of those to you strikes you as the likely even to go everywhere, even if the patient is immunocompetent?
Yeah, so, well, Lyme could be anywhere, even if you are immunocompetent or not. Also, these endemic mycoses are also related to how big is your exposure. Maybe because you're immunocompetent, but your exposure is daily, and that would be an increased risk factor. And TB, well, maybe it's a little far because I don't know. Maybe this patient has TB or not, but he's still immunocompetent, and to have TB, you have to. I don't think he has a risk factors or there is an endemic place. So yeah, I'm thinking about if there is a big exposure, so some endemic mycosis, and if not, Lyme or some. I'm still thinking about gonococcus.
I agree. I'm glad that you didn't put away Lyme and gonococcus. I think that those are very important to think about. And I think if you look at the rash closely on the nose, it's very unusual for Lyme or gonococcus to cause such a deep ulceration. Usually it's small lesions. But here, I'll just share one pearl. If you take all the endemic mycoses and you put them in a line of virulence, meaning most likely to cause disease, disseminated disease in an immunocompetent host, it's blastomycosis by far. It's not even close. So all of them can cause localized disease in anybody. You can get sporotrichoid, you can get pulmonary histoplasmosis, but disseminated disease, blasto. Anyone can get disseminated blasto. And I'm also cheating a little bit because the nasal lesion is characteristic of blasto. You might have seen pictures of that already. Blastomycosis for the oral mucosa in the United States is like paracoccidiomycosis in Brazil, where there's a lot of disfigurement. So whenever I see that, there's a high chance it's blastomycosis. So if we reframe this case as we say, hey, this is a 53-year-old man who is immunocompetent, who is a landscaper, who presents with arthritis and nasal skin lesions, I think it's a very high chance for blastomycosis. But high chance doesn't mean that's the only thing that's possible. And I think what would be really helpful is, again, that pulmonary imaging to see, is it really coming from here? Because patients can have a lot of burden with no symptoms at all. All right, Rafa. Yeah. Educate us, please, Rafa.
Excellent discussion. Trying to put on my poker face. Okay, let's see. This one is a kind of a big aliquot, and there's just one more after that we reviewed the diagnosis. So MRI, the left leg showed abnormal marrow signaling the tibia and bones, the forefoot, with osteomyelitis of the left fourth toe and multiple collections in the soft tissues, compatible as abscess. CT of the chest showed innumerable randomly distributed bilateral pulmonary nodules, bronchoscopy with transbronchial biopsy, skin biopsy, and amputation of the left fourth toe. They all collect like tissue samples from that site, and histopathology of all those three sites showed necrotizing granulomatous infection. AFB of the tissues showed no acid-fast bacilli, and GMS stain of the tissues showed broad-based budding yeast. And that's the end of the aliquot.
Well, you're right. Typical step one, broad-based budding yeast. This patient had mycosis.
Yeah, teach us what you know. There may be people here who haven't taken their step test. So what do you know about this?
So, well, this is a classic endemic mycosis, principally localized in the eastern U.S. Near the Great Lakes, and this can compromise the lungs. So it was important to take these images to the lungs. Well, this plastomycosis can disseminate to bone. So this is very particular in this case because he had osteomyelitis, and yeah, and I don't know what else to tell. I know just
That's perfect.
Picture of broad-based budding yeast, very very particular for this fact.
I completely agree. I think this case is humbling because you can just be a normal person and have this devastating infection. But yes, the broad-based bud is a reminder that the answer is also another B, broad-based bud.
Yes.
And I think that there's so many learning points in this case. I'm curious, Chiara, now that you've gone through this journey, I know Rafa hasn't told us the answer yet, but what did you learn new that you didn't know before that really stuck out to you?
Actually, I completely forgot endemic mycosis. I was thinking about many things, and then, oh yeah, this exists. I forgot completely. After you said that, it is very, very, very important to know that blasto can happen in people that are immunocompetent, because this was our patient, an immunocompetent patient. So blasto can happen here, and those are the things that I forgot, of course. What else important to think? a patient that does not improve with antibiotics, it's important to think about abscesses, which this patient had, and yeah, always check your related behaviors, because landscaping very important for this disease.
Amazing. And how I couldn't agree more. How are you feeling in terms of your nervousness now compared to the beginning?
Still nervous.
Yeah.
Yes.
Why do you think
Yeah.
you're so nervous?
I'm cold.
Oh, but you're always cold.
Oh yeah, that's right. Yeah, I was nervous because we, I don't know. We have an amazing, excellent, extraordinary audience. So
Mhm.
definitely they know a lot. So I
Yeah.
was nervous, like, hey, maybe I have less to teach. But also we have a very great, amazing mentor here, Ravi Iha. So I was nervous, like, not to say the correct things, but I always feel very confident in VMR. I know, for all those who don't know, Ravi, he loves people that say, I don't know, because that's the best way, opportunity to learn and never forget things. So
Yeah.
that makes me feel comfortable.
Yeah, look, the audience is already telling you how you did, so maybe you should trust them like you trust them with everything else. But truly,
Yeah.
ask yourself what you just did. You came and publicly discussed a case that people couldn't figure it out in real life, right? Like, he had a washout, he had all these things, and you're by yourself diagnosing disseminated blastomycosis. That's very hard to do. And so really, really appreciate you making yourself vulnerable and trying your best. And I think it's the only way we grow. And so I know you haven't been in the lukewarm seat for a little bit of time, but I really enjoyed seeing you. I enjoyed seeing you getting nervous and flustered, but also enjoyed seeing you push yourself and share with us so many important teaching points, including everything that anybody needs to know about blasto from your recent step studying. So it came.
Yeah, maybe that's the reason I forgot about disseminated disease, because I want to forget everything about that
Yeah, I know, right?
stuff. Yeah. Yeah,
Amazing.
it's very important.
Yeah, I couldn't agree. Well, Rafa, do you want to tell us what the patient has? Maybe we're all wrong, and
Maybe he
Shema.
has TV.
Yeah, exactly.
Yeah.
Okay, this patient had a urine antigen of blasto and histo, and both were positive. But the final diagnosis was actually blastomycosis, because there's this cross reaction between histo and blasto urine antigen test. The mode was identified as blastomyces by DNA sequencing, and he was initiated with itraconazole, which he took for a year with complete resolution of his skin, lung, and bone findings, and normalization of his serum antigen levels. And that's the end of the case.
Rafa, thank you so much for jumping in to present. Always, whenever you do, we're always up for a treat. Thank you. Really, really appreciate it. Alrighty, Ariel and Shema, we'll hand the mic to you to summarize the learning points in this case.
Thank you for awesome discussion. I was telling Shema that I learned nothing about derm, so I'm gonna leave the skin part to Shema. So talking about joint pain, we want to know that it's inflammatory versus non-inflammatory, and then the big buckets that we can apply thinking about joint pain. First, we want to rule out infection, like septic arthritis from a pyogenic like Staph aureus or disseminated gonococcal infection, but also think about infectious endocarditis, Lyme disease, stuff like that. And then if we can rule out infection, there can be rheumatologic or autoimmune diseases to think about. In our patient, with a culture negative septic arthritis, then the most common bugs would be TB, Lyme disease, some fungal disease. And Robbie reminds us that the bacterial and fungi that can cause these septic arthritis always come outside of the human body. So we need to think about the exposure, like is the patient exposed to ticks, endemic fungus, or some weird bacteria like TB. And then we learned that the patient is a landscaper, is that a word? So we're focusing on like endemic mycoses for southeastern USA. We are thinking histoplasma, blastomycosis, stuff. And when we think about endemic mycosis infection, we always want to get pulmonary imaging because of the route of transmission. And then for immune competent host contracted with disseminated fungal disease, blasto is by far most likely than any others. And then I'm gonna leave the skin part to Shima.
Okay, so we were also talking about pustular skin lesions. If we think of the infectious agents, think of Neisseria gonorrhea or sporotrichosis and also TB. And if you think of the autoimmune part, we're talking about there's the Cepho syndrome, as it was also mentioned, I think like 2 weeks ago. That's basically an acronym for synovitis, I think there was arthritis, and this pustular acne and osteitis. And then also thinking of the pustular form of psoriasis and also acne pustulosis. And then also a nice pearl that was also mentioned by Rafa when we talk about the detection of blastomycosis, that there is the cross reaction between histo and blasto if we use the urine antigen test. And so we would rather use a DNA sequencing test for detecting blasto, and the therapy that is used here is itraconazole. Yeah. So thanks a lot. And I also want to say how impressed I am with Ariel. You all have to know that she is a first-year vet student, and that's really impressive what she already did here. So yeah, a big shout out to Ariel, and also to Chiara for the amazing discussion. I learned so much.
Absolutely amazing, y'all. Thank you so much. We'll hope to see you tomorrow for RLR at 9 a.m. Pacific. Bye.
Bye, friends.
Bye.
Bye.